request Kalpana Datta madam to welcome all and start the meeting. Over to you, Professor Datta.
Thank you, Dr. Shapun Roy. Good afternoon to everyone. And welcome to you all in the last clinical meeting of this year of 2023. I think this is the last one, and we had a nice online and offline clinical meeting for the whole years, and it's full of activities, academic activities throughout the year. I really thankful to all of you, all the members of WAP, giving me the opportunity to serve you as a president. And this is my last president clinical meeting. So I welcome you all, and I really thanks Dr. Bandyopadhyay for arranging. Pardon? Dr. Devashish Bandyopadhyay for arranging the clinical meeting online, because we used to have an offline also in the DRC. Now this time, because of the many colleges has been included in this clinical meeting, so we kept some online and offline. So this time is offline, online. Maybe in the next year you can get the chance of offline too. So without wasting much time, I request moderator Dr. Devashish Bandyopadhyay, please start the presentations. And who will going to moderate, you or someone else? Dr. Devashish, are you going to moderate?
Actually, Devashish will be moderating.
Okay, so you just introduce your first speaker and start the presentation. Ask your president to present the case, and just let them know the time also. It should be limited, stipulated limited time. Okay, over to Dr. Devashish Bandyopadhyay.
So, Dr. Banerjee, are you there? Hello. Devashish, are you there?
Unmute korun. Unmute korun. Muted রয়েছে.
Devashish, please unmute yourself. Yeah.
Okay.
So I'll request Dr. Devashish Bandyopadhyay to introduce your first speaker. The time
Good
limit.
afternoon. I am audible.
Yeah, you are audible.
Yes.
Okay, a very good afternoon, and it is a rare privilege. We are really grateful from the Eastern Railway, B.R. Singh Railway Hospital Department of Pediatrics to West Bengal Academy of Pediatrics for giving this rare opportunity to present our interesting cases on this platform. We have a list of 5 speakers, but the last speaker, due to an unfortunate incident in her family, she could not turn up. So we will be limiting our today's program to 4 case presentations by the DNB PGTs of our institute in the pediatrics. And I will request the first speaker, Dr. Sandeep Shivapuja, to kindly present his first case.
Ask him to share the screen first. Huh?
শেয়ার করতে হবে নতুন করে
স্ক্রিনটা শেয়ার করতে প্রথমে যেটা বলবে সেটা ডেস্কটপে খুলে রাখবে, দেন শেয়ার স্ক্রিন করে
ক্লোজ
ক্লিক
कर
করবে।
दीजिए, क्लोज करके फिर नया कर क्लोज कर दीजिए। Down.
Is this okay?
Down. Down arrowটা প্রেস ডাউন অ্যারো প্রেস করো, তাহলে নেক্সট স্ক্রিনটা চেঞ্জ হবে। হ্যাঁ, রাইট, ঠিক।
Please continue.
Good afternoon, everyone.
आप उधर ही बात कीजिए, इसमें बात करने की जरूरत।
Good afternoon, everyone. My name is Dr. Sandeep, PGT BR Singh Hospital, Pediatrics. My topic is the worst nightmare came true. A 3-year-old boy born out of non-consanguineous marriage, the first order child with uneventful perinatal history, was brought to our OPD by his parents on Jan 5th, 2023, with complaints of rashes since 10 days, blood in stool since 1 day. History of present illness: multiple pinpoint bluish spots, non-itchy, appeared initially on right thigh, extended to left leg and abdomen. And history of one episode of blood in stool, which was dark brown in color. There was no history of trauma, fever, bone or joint pain or swelling, blood in urine, or there is no history of any other bleeding manifestations in the family, no history of any drug intake, any convulsions, weakness, or any bite injury, or any abdominal pain. In the past history and family history was insignificant. And birth history, the child was born out with twin pregnancy. In preterm, it was a preterm at 32 weeks with low birth weight of 1.75 kg, which was appropriate for his gestational age. Through vaginal delivery, the baby was a weakless baby, and NICU admission was done for feed management. The immunization was as per schedule. Dietary history: the baby was exclusively breastfed for initial 6 months, and later on he was on home-based diet, which was a non-vegetarian diet. And developmental history was appropriate for his age, and anthropometry was normal for his age. On examination, the child was playful, no abnormal feces. The vitals were normal, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or any edema. In head-to-toe examination on skin, there was a multiple petechiae and ecchymotic patches over both the lower limbs and abdomen. The petechiae, the 0.5 to 1 or 0.5 mm to 1 centimeter, multiple, bluish, non-blanching, macular, non-itching. Ecchymotic patches were 6 in number, which was 3 to 5 centimeters in size. In systemic examination, chest bilateral air entry was present. In CVS, S1, S2 was heard, no added sounds. Per abdomen, soft, non-tender, no organomegaly. CNS was within normal limits. On local examination, in per rectal examination, on inspection, no active bleeding was present, no hemorrhoids, fistula, or fissures. Summary: so we have a 3-year-old boy born via vaginal delivery at preterm and was low birth weight, had normal development, presented with complaint of multiple bluish skin spots and an episode of blood in stool, with no evidence of any systemic and local infection, trauma, insignificant family history. My differential diagnosis are immune thrombocytopenia, aplastic anemia, and acute leukemia. And investigations, the hemoglobin was 10.6 gram per dl, which is mild anemic for his age, and platelets were less than 10,000. LFT, RFT electrolytes and other investigations were normal, within normal limits. His urine REME was normal. Stool examination, no OVA parasite cysts or no any occult blood. Blood grouping was A positive. Prothrombin time was 13.3 seconds and INR 1.1. APTT was 32 seconds, which was normal, and serology was negative. In peripheral smear, there was microcytic hypochromic RBC, no atypical cells, severe thrombocytopenia, no parasites are noted. The 3 units of platelet concentrate was transfused, and bone marrow aspiration was done. The bone marrow aspiration study showed cellular marrow with normal hematopoiesis, megakaryocytes were present, no abnormal cells. And final diagnosis was made as immune thrombocytopenia. And treatment: on day 1, child had blood in stool and platelet count was less than 10,000. So IVIG at the rate of 2 gram per kg over 2 days were given, and the platelet concentrate were given. On day 6, the child had another episode of epistaxis, and platelet count was less than 10,000. So again, platelet was transfused at a rate of 10 ml per kg, and IV methylprednisolone was started, pulsatile dose 30 mg per kg per day for 3 days, and followed by oral tapering by oral agents. And on day 22, child had another episode of epistaxis and had petechiae, and platelet count was less than 14,000. So a thrombopoietin agonist, L-thrombopog, was started orally. 25 mg OD. And the child platelet count gradually improved to 24,000, and there were no further episodes of bleeding. So the child was discharged on tablet L-thrombopop 25 mg OD and oral steroids, which were gradually tapered, and oral PPI. Child was followed regularly on OPD basis. And back to square one. 1 month later, child was admitted with multiple ecchymotic patches and platelet count was 5,000. So again, injection methylprednisolone was given for 3 days and followed by oral steroids. Injection romiplostin was started, 25 microgram per kg, 25 microgram subcutaneous per week with oral steroids. And symptoms controlled, but platelet counts were remained same. Platelet count did not improve properly. And child was discharged with injection romiplostin, 25 microgram weekly injections, oral steroids, and PPI. Child was asked to avoid any contact sports, any intake of any NSAIDs or IM injections. On follow-up, injection romiplostin dose was increased to 75 microgram in view of persistently low platelet count. And a child was receiving weekly injections of romiplostin and was stable without any bleeding episodes or PTK or ecchymosis. Child last received injection romiplostin in August 2023 and lost to follow-up for 3 months. And the worst nightmare, 3 months later, the child was admitted with a complaint of focal seizure of right lower limb and right upper limb since 3 days. On examination, the child was conscious, alert. GC was normal, 15. Pulse rate was normal, and BP was 120/70, which is higher outside, and pupils were bilaterally reacting to light. The power and plantar reflex. The power in the right upper and lower limb was 3/5, and the right plantar was extensor. The platelet count was less than 10,000. MRI was done, which revealed mild early subacute hemangioma in left frontoparietal region with perifocal edema and mild mass effect. Microhemorrhage in bilateral cerebral parenchyma. The MRI report, which suggests hematoma on the left side, left cerebral parenchyma. The treatment given, airway breathing and circulation was maintained, head end elevation was done. Tablet amlodipine was given for 2.5 mg stat and OD. Injection phenytoin was given for convulsions, 20 mg per kg bolus, followed by maintenance dose of 5 mg per kg per day. IVIG was started 2 gram per kg over 2 days, and injection methylpred was given in pulsatile doses for 3 days, along with platelet transfusion at the rate of 10 ml per kg. 3% NS was given at a dose of 1 ml per kg per hour to reduce ICT. Neurosurgery consultation was also done. In recovery, the injection romiplostin dose was increased to 200 microgram weekly injections, and phenytoin was converted to oral valproate, and lacilactone was added to control BP. Child responded to treatment with no bleeding manifestations. Physiotherapy was initiated. Power improved in all limbs with mild residual weakness of right side. Power was 4/5 at the time of discharge. Child discharged with oral anticonvulsant and oral steroid. Child is now receiving injection romiplostin 200 micrograms subcutaneous and is stable without any new symptoms. Discussion. Usually the prognosis of ITP is good. Severe bleeding manifestations are seen in 3 to 5% of cases. Intracranial hemorrhages are rare and worst complications of ITP, which is seen in less than 1% of cases. It usually leads to death or severe neurological deficit in the child. Incidence of chronic ITP is 10%, of which large majority achieve remission in second year of illness. And the take-home message, complete response to treatment of ITP may take from several months to years. Proper counseling of parents about the condition and duration of treatment is must. And all complications of thrombocytopenia has to be explained to parents and advised not to stop treatment in between. Thank you.
Thank you, Dr. Sandeep Sibpuja.
Yes, ma'am.
For your, for your nice presentation. What is the age of the patient?
3 years, ma'am. At the time of when the patient came first, he was 3 years old.
And what is the level of platelet after the last episode of ICH? When you discharged?
When discharged, he was discharged at a platelet count of 25,000, madam.
Okay.
Now he's receiving romiplostin injections, 200 microgram. And the last week he has done platelet count. It was 1,60,000, madam.
Okay. Thank you. Very nice case. Any questions from the house? I think now the questions are case is open for discussion.
It is, Kalpana, ma'am, it is difficult to answer questions online. So I would request the audience to post their
write
questions
down
in
in the
the
chat
chat
box.
box, and then we will answer it adequately.
Sure.
So,
all
thanks,
the
Dr.
admins
Sandeep.
and panelists requested to write down your questions in the chat box and it will be answered there.
It
Okay,
will be
question,
attended.
I think, why have you changed amlo to lacilactone? There's one question was there. So write it down the answers. And as you have shown the case of ICH, as we are having a regional institute of hematology in our college, we do get many cases of ICH because it is a referral center in the Eastern Zone. So we do get varieties of ICH in case of ITP. So it's not that rare, but 3 years, okay, it's very less, very young age, tender age for having this. So, and during the discharge, the child have any residual paralysis, or it was improved?
Yes, madam. Residual neurological deficit was there, ma'am.
Okay, residual paralysis.
I have written that. Yes, ma'am. Power was 4/5.
Did you do the follow-up of MRI for this hemorrhage, the size is decreased or increase or any improvement in the hemorrhage?
We'll do later, ma'am, on the later stages. It has been only 1 month, so we means
okay,
we'll
so
do
clinically
after
follow up
that.
and it has to follow up by radiologically also. Okay.
Yes, ma'am. Yes, ma'am.
So thank you, Dr. Sandeep, for a nice presentation and discussion. Over to Dr. Devashish.
Thank you.
Dr. Banerjee, I'll request you to pick up, as you are the moderator, pick up the questions in the chat box. Someone has posted in the question answer also. I'll request everyone not to post any question in the question answer. Better do it in the chat box. And Dr. Banerjee, please answer to these questions, what has been posted there. Not in the chat box.
The questions will be answered in the chat box.
Not chat box. You can answer over here. You just pick up the questions. You just read it out the question and just give the answer. So it will be audible to all.
We are short of time now.
No,
I will be answering in the chat box.
Okay.
So actually what happens, this is a multi-specialty hospital. We have in-house and out-house tie-up also, or different specialties. So we acknowledge that the help we are getting from West Bengal Academy of Pediatric Doctors, as well as the different super specialty hospitals in Kolkata. We even at times when we are in doubt, we take help of referral centers like AGPJ Lucknow and AIIMS New Delhi. So that advantage we have, and the molecules that are available in the railways, it helps the railway beneficiaries to continue this costly treatment, which is not available in the general population. So in that way, the patients are doing well with this type of costly treatment, and it is by the goodwill of the patient party that we continue. But here what unfortunate happened that the patient was lost to follow-up. They had went for some alternative medicines thinking that there is no respite from disease in allopathy treatment. So I would call upon the second speaker, Dr. Ayesha.
What is the name of second presenter?
Ma'am, Dr. Aisha. It is stuck. Can you just give me a minute, ma'am?
No. Ask the previous presenter to stop sharing. Okay, then you'll share. Okay, now Aisha.
हैंग कर जा रहा है ना बीच बीच में। अच्छा, रिकवरी के ऊपर डबल क्लिक कीजिए। रिकवरी के ऊपर डबल क्लिक कीजिए। थोड़ा वेट करिए, आ जाएगा थोड़ा टाइम।
Is there any technical hitch, Somnath da?
Sorry, sir.
ল্যাপটপে চার্জ ছিল না।
हाँ हाँ, चार्जर लगा दीजिए।
ঠিক আছে, ওকে।
Is it okay, sir? Good afternoon, everyone. I'm Dr. Aisha, DNV PGT from BR Singh Hospital. Today, I'm going to present a case titled A Bloodstained Diaper. My case is of a 7-month-old girl child born out of non-consanguineous marriage, first order, with uneventful perinatal history, who was brought to our OPD by her mother with complaints of pervaginal bleeding for 2 weeks. History of presenting illness. The bleeding was initially barely notable, but gradually progressed to significant amounts, staining diapers, which aggravated on passing stools. There was no history of trauma and abuse, foul smelling or white discharge, fever or cry during micturition, blood in urine or any other bleeding manifestation, rash or drug intake or abdominal distension. Past and family history was insignificant. Birth history was unremarkable. Immunization history, child was immunized as per NIS. Diet history, child was on exclusive breastfeeding for initial 6 months, now on weaning diet. Developmental history was as per age. Anthropometry was within normal limits according to age and sex. On examination, child was playful and no abnormal facies, exhibitors of choice. Vitals were all within normal limits. There was no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Head-to-toe examination was insignificant. Systemic examination were all within normal limits. On local examination, per vagina, on inspection, there was active bleeding. Genitals appeared normal. There was no evidence of trauma, excoriation, or any mass. Summary: 7-month-old female child with uneventful perinatal history and normal development presented with complaints of gradually progressive, painless vaginal bleeding since 2 weeks, with no evidence of any systemic and local infection or trauma or bleeding diastasis in family. So we came to a differential diagnosis of local infection, of any deep-seated trauma, foreign body, or any vaginal polyp or malignancy, a vascular malformation, or maybe an ovarian or endometrial malignancy. We did first line of investigations, which was lab investigations, and which revealed mild anemia. Other parameters were normal. LFT, urea creat, electrolytes were all within normal limits. Urine REMA and stool for OBT were all negative. INR was normal. CRP was less than 8, non-reactive. We did second line of investigation, which consists of tumor markers and hormonal studies. LH, FSH, progesterone were all normal. And tumor markers, beta HCG was negative, but AFP was raised. That was 183. Next, we did radiological investigations, starting with USG whole abdomen, which revealed prominent follicles seen in right ovary. We did MRI abdomen, which revealed a well-defined enhancing soft tissue lesion in vagina is extending into fornix, likely neoplastic. There was also a bilocular cyst with thin non-enhancing septation in right ovary. So a team of pediatrics, gynecologists and pediatric surgeon were consulted. We decided to do a cystovaginoscopy. So cystovaginoscopy was done under general anesthesia, and a vaginal mass was noted, of which a biopsy was taken and sent for histopath. Other pelvic organs appeared normal. And histopath report revealed malignant tumor composed of sheets of large cells with large vesicular nuclei, prominent nucleoli, and abundant vacuolated cytoplasm. Few multinucleated forms were also noted, brisk mitotic activity seen with focal areas of necrosis. Second, this is the histopath report. This was the low power field which showed areas of necrosis. And the second slide is of a high power field showing sheets of large cells with large vesicular nuclei, which can be seen here, and prominent nucleoli and abundant vacuolated cytoplasm. The impression was that of malignant tumor favoring germ cell tumor, most likely embryonal cell carcinoma. So we came to a diagnosis of germ cell tumor, likely embryonal carcinoma of vagina. The treatment consists of an initial whole body bone scan, which was negative for osteoblastic skeletal metastasis. Child was staged as a standard risk and started on chemotherapy according to JV protocol, which consists of 4 cycles. Each cycle consisted of carboplatin, bleomycin, etoposide at an interval of 21 days. The bleeding fortunately subsided after the first cycle itself. The chemotherapy was uneventful. On follow-up, labs and radiological investigations were all normal, suggestive of no residual lesion. Child is developmentally normal and is symptom-free at present. So discussion. Germ cell tumors and gonadal tumors are very rare, with an incidence of just 12 cases per 1 million in people younger than 20 years. GCTs arise from primordial germ cells. They may be classified as seminomatous or non-seminomatous, and seminomatous has a better prognosis, gonadal or extragonadal, intracranial or extracranial. Non-seminomatous GCT may be embryonal or teratoma or yolk sac tumor or choriocarcinoma. Extragonadal GCTs very often occur in the midline. Primary vaginal carcinomas are very rare and are mostly metastases, which constitute of the majority of cancer found in vagina, that is 84%. Important DD for vaginal carcinomas is sarcoma boteroides and is primarily differentiated based on HP. Poor prognosis is indicated by any of the following, which includes mediastinal primary, non-pulmonary visceral metastasis, or poor markers such as AFP more than 10,000 or beta HCG more than 50,000. Take-home message. It is important to remember that alarming and unusual symptoms call for intensive lab and radiographic studies. Early detection of GCT is very important because of its aggressive nature and good response to chemotherapy. It is advisable that all young females with unexplained vaginal bleeding should undergo a detailed evaluation, including alpha-fetoprotein estimation. A multidisciplinary team approach always helps us broaden our horizon in terms of diagnosis, treatment, and learning. Thank you.
Thank you, Dr. Aisha, for a wonderful case. It's really very rare case. We have hardly
Thank
seen
you.
any one and two cases only. And the outcome was also good. And how long will you follow up the patient? And what will be the frequency of follow-up?
Ma'am, initially the child was followed up regularly after, for the chemotherapy was spaced at interval of 1 month each. So 1 week prior to the second cycle of chemotherapy, child was advised to do routine investigations such as CBC, LFT, urea, creat. After the fourth cycle, child was followed up every 2 weeks initially, followed by 1 month, and now child is advised to visit every 3 months, ma'am.
Okay, thank you. So I think Dr. Devashish, you can invite questions from the house. And there are few questions, I think, on the chat box.
Okay, madam, the answers will be given in the chat box, no problem.
Okay.
So this is a arena where we are dealing not only with pediatrics, but pediatrics with malignancy, which is a really highly sophisticated field of treatment. And in this case, as obvious, we had to take help from our super specialist friends who are there in Kolkata. And in this context, I acknowledge my thanks to the pediatric surgeon, the pediatric oncologists who are available in Kolkata. And they are outside the railway purview, but they were kind enough to help us in managing this case so well. So I would call upon the third speaker of the day, Dr. Phanindra.
Good afternoon, everyone. I'm Dr. K. Phanindra, second year DNB PGT from B.R. Singh Hospital. Now I'm going to present a case of pancytopenia. 13 years old female child, first by birth order, born to non-consanguineous parents, presented with a chief complaints of generalized weakness and giddiness since 2.5 months and pain abdomen since 15 days. Child was apparently well 2.5 months back, developed generalized weakness since 2.5 months and pain abdomen from since 15 days, for which she was attending private hospital OPD. History of fever for 1 day, 5 days back. No history of rashes, gum bleeding, or any other bleeding manifestations. No history of vomiting, loose stools or black stools. No history of joint pains, palpitations, convulsions, and no history of any other drug intake. Past history, no significant past history. Personal history, attained menarche 1 year back with regular menses. No history of excess bleeding. No significant family history. Birth history is normal. Dietary history, she takes vegetarian diet. Immunization history is up to date, and developmental history also appropriate for age. Anthropometry is within the normal limits. On examination, child is conscious, coherent, and cooperative. Pulse rate is 80 per minute, or respiratory rate 24, SpO2 99, and BP within normal limit. Child on examination, child has pallor and icterus. No cyanosis or no clubbing, and lymphadenopathy, fesse, enlarged cervical lymph nodes, which are multiple 1 into 1 centimeters, mobile, non-tender, and soft. No edema. All systemic examination was normal.
হয়ে গেছে আমাকে গৌতমকে পাঠাবেন আমি করে দেবো পাঠিয়ে দিচ্ছি ওটা হলো আরেকটা কিছু
Please mute
At
all.
2 examination. At 2 examination, there is hyperpigmentation of knuckles was seen. Investigations with outside reports done on 12 and 15th of July. Hemoglobin was, we can see pancytopenia with hemoglobin 5.8, total count 2,500, and platelets admitted in our hospital on 15th July. Differential diagnosis were acute leukemias, aplastic anemia, sepsis-induced myelosuppression, vitamin B12 deficiency anemia, myelodysplastic syndromes, and infections. On further investigation, hemoglobin was less, MCV was raised more, 104, with evident pancytopenia. CRP was within normal limits. Peripheral smear shows normocytic normochromic RBCs with moderate anisopoikilocytosis. No abnormal cells noted. Lymphocytes noted with predominantly mature lymphocytes. On further investigation, TSB was raised and all other LFT, RFT was within the normal limits. All MPDA, dengue, HPLC, G6 feed and serology was normal. Iron profile shown iron and TIBC are within normal limits, but ferritin is increased. And LDH raised significantly. And normal thyroid levels, calcium, phosphorus, and uric acid levels, PTIN, are also normal. On further investigation, vitamin B12 is decreased. Folic acid is within normal limits. Urine, stool, and USG was normal. Antiparietal cell antibody normal. Anti-intrinsic factor antibody also negative. Serum TTZ IgA was negative. Bone marrow aspiration smear shown erythroid hyperplasia with megaloblastic changes in erythropoiesis and about 20% dysplastic erythroblasts seen. Smear reveal erythroid hyperplasia with mildly suppressed myelopoiesis, megaloblastic and dysplastic changes, possibility of vitamin B12 or folate deficiency. Acute leukemia panel not suggestive of any acute leukemia. Diagnosis is vitamin B12 deficiency anemia. We can see hyperpigmentation of knuckles. For treatment, we given injection methylcobalamin 1000 micrograms once daily for 1 week, then weekly for 1 month, then after once a month. We given folate supplementation, iron supplementation, and B complex supplementation. After treatment, after 2 weeks, investigation shown, we can see the normalization of reports with the total count, hemoglobin, and platelet within normal limits, and child clinically improved well. Takeaway: vitamin B12 deficiency can be cause of pancytopenia, predominantly in an unbalanced vegetarian diet. Diet history is an important tool for evaluation and diagnosis of vitamin B12 deficiency anemia. Diet counseling regarding balanced diet should be done at every follow-up visit in these type of cases. Thank you.
Thank you, Dr. K. Fanindra, for nice investigation and presentation, though not rare. Okay, so what was the MCV?
MCV raised it, ma'am.
How much? It should be
104.
more than 90. Yes, 104.
104,
When it
ma'am.
is more than 90, you should thought the first thing comes in mind is the B12 deficiency. Now, did you go for the B12 level and methyl malonic acid and homogeneous acid estimation?
We done B12 level, ma'am. Methyl malonic acid estimation over Nikia. B12 level is decreased.
B12 will not
You can see.
suffice. You have to do that also. Okay.
Mhm.
So did you
Yes,
give when you give the injection of B12?
yes,
What
ma'am.
was the outcome?
After 2 weeks of injection, child clinically improved, ma'am, and we can see investigations also we can see improved TLC count,
Okay.
hemoglobin, and platelet count became normal.
Actually, the hyperpigmentation and knuckles is the characteristic sign. Any child is having anemia with hyperpigmented knuckles, you always rule out
Yeah.
B12 deficiency. So that's
Yes, ma'am.
important. Yes,
Yes, ma'am.
so what was the key message? What message you want to give?
Vitamin B12 deficiency anemia can cause pancytopenia, especially
Yes,
in
yes.
a
It's not okay. Okay, thank you, thank you. So, Doctor,
Thank
over
you,
to
ma'am.
Dr. Devashish. Over to Dr. Devashish. Dr. Devashish, please.
What was peculiar in this case was that the appearance of pancytopenia. We hardly get a case of pancytopenia presenting at the backdrop of B12 deficiency. So it was quite confusing, and we, as I was telling, we have our in-house hemato-oncologist, super specialist. So we took the advice, and it was worked up thoroughly so that we don't miss rare happening like malignancy or that. So it was fortunate for the patient and for the family and for the treating doctors as well that it turned out to be B12 deficiency, which is correctable by simple therapeutic doses of vitamin B12 that has been going on, and the patient is doing well now. So
Yeah,
I would
B12
now call
deficiency,
upon,
one of the cause
yes,
of
please.
pancytopenia is megaloblastic anemia. That is a known fact. B12 deficiency,
Right,
it
right,
can cause pancytopenia, one of the feature.
right.
Okay.
But in general, OPD cases, we hardly get such presentations.
But we have actually I have published 4 cases of B12 deficiency long back, and we do get
Right,
cases
right.
different varieties. Of course, the
Right.
patient load is quite high, and referral center is there, so we are getting
Right.
okay. So nice. Okay,
Uh,
nice. Over to you.
Thank you. So I call upon the last speaker of the day, Dr. Bhagwan, to kindly place his case presentation now. Please.
And please answer. Lots of questions are there in the chat box. Dr. Devas, please answer in the chat box.
Achai, it is not visible in our. I was discussing with Mr. Somnath. So
Ask
it has
him
come
to
now. It
forward
has
it.
come now.
Ah,
Okay. It has come now. We are answering. It has come.
okay.
Very good afternoon. Myself, Dr. Asif. I am a DNB resident at BR Singh Hospital. I'm going to present the case of diagnostic dilemma of a PR blade. Informant being father. My patient name is Titli Haldar, 7-year-old female, second born by birth order, born out of non-consanguineous marriage, Hindu by religion, resident of Howrah, West Bengal, came with complaint of pain in abdomen since 1 month, blood mix, loose stool since 1 month. My patient was apparently all right 1 month back to start with pain in abdomen, which was insidious in onset, intermittent, mostly present in periumbilical region, colicky type of pain, aggravated while passing stool, no relieving factor, non-radiating, non-progressive, with no diurnal variation. The patient also complains of loose stool, which was started 1 month back, which was associated with blood in stool. Uh, in the in the start, 4 to 5 episodes per day. Later on, the episodic increase in the episode episodic increase to 5 to 10 times per day, which is mucoid, semi-solid consistency, non-foul smelling, not associated with bleeding from any other sites, no history of fever, burning, micturition, vomiting, decreased urine output, decreased daily activity. There is history of tenesmus, but there is no history of urgency. There is no history of weight loss, joint pain, redness of eyes, rash, blood transfusion. There is no history of abdominal distension, pedal edema, or periorbital swelling. No history of tuberculosis or any tuberculosis contact. Past history, patient has gone to many general practitioners, pediatrician, and surgery opinion also taken in the last 1 month. Patient is second born by birth order, born out of non-consanguineous marriage with no history of similar complaints in the family or past, no history of autoimmune disorder in the family, no history of major illness in the family. Birth history, it was a book case with a normal and neonatal history, no NICU admission was required. Immunization history is child is immunized till date according to National Immunization Schedule. Child achieved all the milestone as per years of her age. Diet history, my patient is non-vegetarian, consume adequate diet, but it is thin built. Anthropometry, height was 112 centimeter, expected was 119.4 centimeter, lies in 10 to 15 centile. Weight is observed was 18.2 kg, expected was 21.2 kg, lies in 10 to 15 centile. General examination, child general appearance was thin build, pulse is 84 beats per minute, BP was 84 by 60 millimeter of mercury, respiratory rate was 22 per minute, saturation was normal, temperature was normal, pellar was present, there was no icterus, cyanosis, clubbing, lymphadenopathy or edema. Head to toe examination was within normal limit. And systemic examination, inspectory findings are normal. On palpation, there was mild tenderness present in left iliac fossa. There was no guarding or rigidity, no organomegaly was there. On percussion, rest examination is normal. There is on local examination, there was no skin tag, fistula, or abscess. Cardiovascular system is within normal, means S1, S2 is normal, no added sound. In respiratory system, air entry is equal on both sides. Vesicular sounds, no added sounds were there. No focal neurological deficits were there. Cranial nerves examination is normal. GCS is 15 by 15. A summary of my case is that 7-year-old female child with insidious onset of abdominal pain and blood mixed loose stool since 1 month, with no evidence of local or systemic infection and with no significant past history or family history. So in the initial, we kept these differential diagnosis: bacterial dysentery, acute gastroenteritis, lactose intolerance, celiac disease, anal fissure, inflammatory irritable bowel syndrome, Crohn's disease, and ulcerative colitis. In treatment history, my case was actually happened in December 2020. In first initial 1 month, my patient was gone to many pediatricians, general practitioner, and one surgery opinion also taken. In suspect of bacterial dysentery or acute gastroenteritis, my patient was treated with various antibiotics, antispasmodics, and IV fluid. Then patient came to us. We repeated all the investigations, biochemical investigation, viral panels. Then we have taken opinion of our super specialty expert and performed a colonoscopy. In January, the colonoscopy findings, the ulcer in rectosigmoid region. Biopsy findings are cryptitis and cryptopsis. We kept the diagnosis as inflammatory bowel disease unclassified and started patient on aminosalicylates, that is tropical and oral, both mesacol, enema, and mesalamine. Then patient shown much improvement, so patient has been discharged on this. Then patient, after few days, patient has stopped the drug themselves in view of symptomatic relief and failed to came back for follow-up and then lands up in relapse. And then also we have again admitted the patient, all the investigation were repeated, and super specialty opinion was taken and colonoscopy was repeated. There was multiple deep ulcers in rectum and sigmoid region. Biopsy finding were again cryptitis with cryptopsis. We again kept diagnosis similar, IBD unclassified, and again started on mesalamine. This time, patient has not showing symptom as it was shown in the past. So we have started patient on steroid, 20 milligram per day, and then the dose tapered. Again, after tapering the dose, symptom reoccurs. So patient was readmitted, investigation repeated, colonoscopy was done. Again, findings was erythema and loss of vascular pattern in sigmoid and descending colons. Biopsy finding was cryptitis and cryptopsis. So this time, patient was started on the higher antibiotic, high dose of steroid. After starting steroid on higher side, patient shown the symptomatic improvement. Patient was discharged and on recurrent follow-ups, the steroid doses was tapered. But again, on 5 mg per kg, patient land up in relapse. So it was a steroid dependent case. So we have again admitted the patient, colonoscopy repeated, but this time we have upgraded in view of steroid dependence to monoclonal antibodies. Adalimumab was started initially at 40 milligram subcutaneously, one dose, twice weekly, and again once, and subsequently 40 doses of it was given every 2 weekly. Patient was in remission phase from September 21 till December 23 on monoclonal antibody therapy. In between, patient was shown a recurrence of symptoms. So at that time, patient was admitted and methylprednisolone steroid therapy was given for 3 days each. And now the patient is started on budesonide 6 milligram per day. Patient shown much improvement since then. So for 1.5 year, patient was on monoclonal antibody and steroid and in remission. But January of this year, patient was again showing the symptoms in view of adalimumab and steroid. So the patient was the diagnosis was shifted to mostly to the means we were treating, it's like mostly as a Crohn's disease now, but because of the relapses and all, we are mostly thinking about ulcerative colitis also. So we upgraded our treatment to chimeric monoclonal antibodies infliximab. So initial therapy was started at 5 mg per kg. Total 3 doses were given at 0 to 6 weeks interval, with patient shown a remission of the symptoms. So after in 20 April 23, after 3 months, super specialty opinion were taken in view of diagnostic dilemma. But mostly we are now little bit more towards the ulcerative colitis because our symptoms were mostly findings were mostly in the rectum to sigmoid region. The last colonoscopy was uh, superficial ulcers in rectosigmoid junction with erythema and loss of vascular pattern. Transition zone were noted at junction of sigmoid and descending colon. Rest findings were normal. So we started patient on immunomodulator azathioprine. Upper GI endoscopy is also performed at that visit, which is also with a normal limit. CT enterography was performed, which suggestive of mild circumferential mural thickening and stratification with mucosal enhancement. Is seen in involving rectum, sigmoid, and descending colon. Rest bowel loops are within normal. Means small bowel is normal. So our impression is mostly that this is the case of ulcerative colitis. So our lastly patient has till now means our diagnosis is mostly of ulcerative colitis. Patient initially received 3 induction doses and now we are giving 4 maintenance doses of infliximab every 8 weekly. Now patient is complete remission. Discussion. Sir, the inflammatory bowel disease is a group of disorder characterized by chronic intestinal inflammation. It includes Crohn's disease, ulcerative colitis, and inflammatory bowel disease are unclassified. It shows bimodal distribution early in pre-adolescence or adolescent age, and a small increase in cases is also seen at the age of adulthood. Uh, Incidence of ulcerative colitis is 3 times more than Crohn's disease. Etiopathogenesis is that it shows genetic susceptibility, environmental factors, and host immunity is responsible. Ulcerative colitis is a chronic inflammatory condition of gut mucosa and primarily found in rectum and colon, whereas Crohn's disease is a transmural inflammation of GI mucosa and can be found in throughout GI mucosa from mouth to anus. Normally, Crohn's disease affects small bowel and colon. Clinical manifestation of ulcerative colitis is blood, mucus, and pus in stool, as well as diarrhea, are typical presentation of chronic ulcerative colitis. Constipation may be observed in those with proctitis. Symptoms such as tenesmus, urgency, and cramping, abdominal pain, and nocturnal bowel movements are common. These are the comparative factor between Crohn's disease and ulcerative colitis. We will always be in a diagnostic dilemma when the patient comes to us with abdominal pain, bloody loose stool. These are the few differentiating factors like rectal bleeding, diarrhea, mucus, pus is most common with ulcerative colitis, right? Abdominal pain, abdominal mass, growth failure, perianal diseases are most common with the Crohn's disease. There are also some patients shows the extraintestinal manifestation, which is most commonly shown with the patient with ulcerative colitis than Crohn's disease, like pyoderma, gangrionosum, sclerosing cholangitis. So we are always while differential diagnosis, major conditions to exclude are infectious colitis, allergic colitis, and Crohn's colitis. Every child with a new diagnosis of ulcerative colitis should have stool cultured for enteric pathogens, stool evaluation for Clostridium difficile, ova, and parasite. Cytomegalovirus infection can mimic ulcerative colitis. So any child with suspected IBD should be detailed personal history, family history, physical examination, and growth assessment should be done. All the baseline investigation should be performed, and a colonoscopy with ileoscopy and biopsy from all the segment with UGI endoscopy should be performed. We will get a case definitely like ulcerative colitis or intermedia or Crohn's disease. So, which should be mostly evaluated with small bowel evaluation with CT enterography, MR enterography, and capsule enterography. Then we are going to classify the disease extent and type into ulcerative colitis, Crohn's disease, or inflammatory bowel disease unclassified. Treatment of uh, IBD should be induction and maintenance therapy. So, in case of ulcerative colitis, mild disease should be started with 5S plus tropical mesalamine. Moderate should be started with steroid therapy, and acute intravenous steroid should be first line, immunomodulators, and surgery. So, surgery is in case of ulcerative colitis can be a treatment modality end stage, but in case of Crohn's disease, surgery is not means a treatment. The Crohn's disease mostly should be managed by medical management. Ulcerative colitis after remission should be maintained by azathioprine and aminosalicylic acid in maintenance therapy. So my take-home message from my presentation is that the inflammatory bowel disease, specifically ulcerative colitis, which is of a chronic nature condition, it is characterized by inflammation of colon and rectum. So the importance of individualized treatment plans, ongoing monitoring, and potential impact on the patient's quality of life. The treatment line should be individual based. Because this case, inflammatory bowel disease, is a case of remission and relapses. So every time patient comes with a new symptom, the treatment line of treatment will be changed according to that. Psychosocial issues for the child with ulcerative colitis or in the matter of any IBD in the sense of being different. Recurrent admissions were there. So patient was more concerned about body image, difficulty in not participating in fully age appropriate activities, family conflict brought on by them with added stress of the disease. So we should provide social support. Is also important component of management of the disease. Thank you.
Okay, thank you, Dr. Astin, for elaborate presentation of ulcerative colitis, but always you learn how to make it short. It's a quite long presentation, though cases are also very complicated and nicely executed. I think these are nice cases. All the cases are very nice. Dr. Devashish, please just come in and take over the charge and ask the questions from the panelists or any attendants.
Right. So idiopathic chronic intestinal inflammation, it is a chronic process. So that is unpredictable exacerbations and remissions are there. And there is a tendency that is being seen these days, there is the increased incidence among young children. So increased use of antibiotics in the younger age group, and even in Nelson it is written high rates of vaccination may be the etiological cause of this inflammatory bowel disease that is increasing with the years. So what is the problem? The medical cure for ulcerative colitis is not available. We are just having remission, not a cure. So at this juncture, I would like to acknowledge the specialist with whom we had a collaboration and they helped us a lot, including the pediatric gastroenterologist, the in-house, our adult gastroenterologist, and the pediatric gastroenterologist who are there in Kolkata and even in SGPGI Lucknow. So with their blessings, the child is continuing with this treatment modality, and we are with crossed fingers hoping for the best outcome of this child in the near future. So it is a privilege on our part that our administration has given us the chance. Our medical director is in there in the audience, along with our health and family welfare chief administration, and we are having a nice academic session in our institute, and we are thankful to Indian Academy of Pediatrics as well for giving us this chance at the year ending. And we had a Merry Christmas yesterday, and I wish Happy New Year to all and the best to come. Hope for a better New Year 2024. So I would request the West Bengal Academy of Pediatrics to announce the results of today's presentation.
So thank you, Devashish. Actually, these 4 cases are very good, although the last one is a bit longer. So give them the time span because they need to speak within a stipulated time period. And I would request
Right,
Professor.
I tried to complete within 3 because we had 5 speakers. Unfortunately, the last speaker was out. So I gave them this chance. I should not have. It should be time prescribed, as you are telling. Right, yours.
So I would request our president, Professor Kalpana Datta, to announce the prize. Actually, everybody has won the prize, but as a customary, we'll just give prize to first and second, and each certificate will reach you very soon. So I'll request Professor Kalpana Datta to announce the prizes. Professor Datta. Madam.
Yes, I was muted. Thank you, Dr. Shaman. Before announcing the result, I would like to hear from Dr. Atanu is there. I can see Dr. Sushmita is there, and all other dignitaries who are there in the panelisting. I would like to hear from you people a few comments because the last clinical meeting of this year, and it's a nice cases. All are presented well. And they've done justice to the time and case also. So I'd like to have few comments from the panelists like Dr. Atanu.
Yeah.
As Dr. Atanu is there, I can see Atanu bolo.
Thank you, Kalpana Di. So, বছর শেষে দারুণ একাডেমিক এরিয়া আমরা শেষ করছি, and we look forward to the next year, as Devashish has said, and hospital for the adolescent workshop during the West Bengal Pedicon. So I thank the authorities of the hospital for coming forward and letting us organize academic sessions on behalf of West Bengal Academy of Pediatrics, and we hope to do central programs also in the next year. And again, I would thank Devashish and full team. It is a wonderful academic session, and I managed to join it a bit later because this is a peak time in the hospital during that. I almost miss every time the clinical sessions, but thankfully I was there in one of the best sessions of this year. Thank you.
Thank you, Dr. Atanu. Even I'm having OPD, busy OPD, and I came out from the OPD and attended this same again. I have to join there. The first, all of them have done nice. Dr. Shandeep, Dr. Aisha, Dr. Phanindra, K. Phanindra, and Dr. Ashish, they have done very nice presentations. But as a customary, as Dr. Shapan already said, we have to announce the first, second. Dr. Aisha has secured the first position. Congratulations, Dr. Aisha. And Dr. K. Phanindra, Dr. Shandeep Shiva Puja has secured the second position. So congratulations, Dr. Shandeep. And if you can say the third, I think the combined third will be there, Dr. K. Phanindra and Dr. Ashish. They have done equally well. So third position, they are combined in the third. So this is the result of the today's session. And I wish all of you a Merry Christmas and Happy New Year. And we had more than 25 clinical meetings, not only 12 into 2. It is, I think, not more than 25. This is a wonderful job done by all the IIP members of this state. Thank you all. And this is all from my side. Thank you, and over to Dr. Devashish.
Unmute করে নাও।